Welcome, everyone, to the EKG case of the week for June 24th, 2012. This week's case, initial case at least, was provided by Dr. Scott Williams, who's an attending physician at York Memorial Hospital in York, Pennsylvania. I ran into him at a board review course, and he had this EKG to present. He's a 51-year-old man that he and his colleagues took care of, who presented with severe shortness of breath. And what they noticed on this EKG was a bunch of T-wave inversions, which at first glance would make you think that this patient's shortness of breath is due to diffuse cardiac ischemia. However, they knew a little bit more, and what they were able to diagnose based on this EKG, the presence of T-wave inversions in the anteroseptal plus the inferior leads together. Turns out, as we've talked about before, that EKG abnormality is very highly specific for pulmonary embolism. That's what this patient ended up having. T-wave inversions in the inferior plus anteroseptal leads together. When they occur simultaneously, that's highly specific for pulmonary embolism. This was something that was first described by Marriott a number of years ago, and it's been published in other literature. It's starting to make its way into emergency medicine articles as well. And we actually talked about this on the video casts back in December, but there's a few cases that have come across my desk, including Dr. Williams' case, that made me want to just go over this once again. So what you see on this slide, this is the classic thing that we've all learned about pulmonary embolism. We've all learned, unfortunately, that pulmonary embolism produces sinus tachycardia. And when I poll audiences, oftentimes people will say, on the order of 70 or 80% of PE cases produce sinus tachycardia, and that, unfortunately, is a myth. It turns out that in the biggest international studies that have been done on EKG abnormalities of pulmonary embolism, only 30 to 50% of patients with proven PE will produce a sinus tachycardia. So the majority of these patients are actually not tachycardic. In fact, the patient that Dr. Williams presented was actually running a heart rate in the 90s, so not quite tachycardic, but nevertheless, that's something that continues to get drummed into the heads of medical students and residents around the country and probably around the world also. Bottom line here, don't rely on tachycardia, even though it's classic. Most of us have probably learned about this classic S1 Q3 T3 finding, right? A big S wave in lead 1, Q wave in lead 3, and a flip T wave in lead 3 as well. Or sometimes maybe there's just an S1 and a Q3. Bottom line, if there's a big S wave in lead 1, it's a rightward axis, and that's classic, and classic in medicine, as you know, means not that common. Probably about 15% of patients with a proven PE will have that S1 Q3 T3, and a lot of patients that are normal and asymptomatic and don't have PEs will have an S1 Q3 T3. That means that finding, although classic and always being taught, is neither sensitive nor specific. But anyway, it always shows up on the boards, so it's something worth knowing about. And then another finding for right heart strain is a new right bundle or an incomplete right bundle branch block pattern, or simply what you'd look at and see a tall R wave or R prime wave in lead V1. That's a sign of right heart strain. Well, there's a few other things that you should look for in PE cases as well. We know PEs can produce atrial dysrhythmias, SVT, atrial flutter, atrial fibrillation can be produced by pulmonary embolism. You can even have runs of ventricular tachycardia from pulmonary embolism. That's probably not a big surprise to people out there. Here are a couple things that for people that haven't been keeping up with the EKG literature or the EKG videocast, you may not know about this, that PEs can produce ST elevation or ST depression, not necessarily that commonly, but it can mimic a STEMI or a non-STEMI. And the other way that PE can mimic non-STEMI is with T-wave inversions in the inferior and anteroseptal leads. And this is what I actually want to talk about in this brief segment, because flipped T waves, I think we've all learned flipped T waves equal cardiac ischemia, and it's very rare for people out there to teach that flipped T waves are actually not specific for cardiac ischemia. Flipped T waves, in fact, are very common in cases of large PEs, And when you look at the EKG literature, which just looks at large pulmonary emboli, what you find is that new T wave inversions may very well be as common, if not more common, than sinus tachycardia. Again, in cases of large PEs, flip T waves are fairly common. Maybe as many as 50% of patients with large PEs will show up with a new T wave inversion or new T wave inversions in an anatomic area that make you think that they're having ischemia. And Marriott talked about this several decades ago. When you see the combination of T wave inversions in the anteroseptal plus the inferior leads, that should be thought of as pulmonary hypertension. And in emergency medicine, pulmonary hypertension, especially if it's new pulmonary hypertension, new flip T waves in the inferior anteroseptal leads, is PE until proven otherwise. And that's what showed up in Dr. Williams' case. Let me show you another case. This was given to me by someone within our system just probably about a month after Dr. Williams gave me his case. Here's another patient, 49-year-old woman that presented with chest pain and shortness of breath. Notice the heart rate is in the 70s. This patient is not tachycardic. Chest pain, shortness of breath. This patient had borderline instability. This was a fairly large PE, and you'll notice that there's flip T waves in the inferior and the anteroseptal leads. And people who don't know about this EKG literature would be inclined to say this is cardiac ischemia, and it's not cardiac ischemia. This is actually a big PE. And here's one more case just to really hammer this home. This was given to me by one of our residents, Dr. Zach Desmond, who also collects EKGs and gives me a lot of great cases. This patient has a sign of right heart strain. In fact, it has a full-blown right bundle branch block pattern. There's that big RSR prime in lead V1. You'll also notice that there's a little bit of ST depression in this case. Now, it's normal to have ST depression in right bundle branch blocks in V1, V2, V3, but what's abnormal, there really shouldn't be ST depression in other leads in a right bundle branch block. There's ST depression in those leads there. And what also you should not normally see, you can see some T wave inversions V1, V2, maybe V3 in our normal right bundle, but these T wave inversions in V2 and V3 are a little bit more than you'd expect. And also you see T wave inversions in all of those inferior leads, and that's not normal with the right bundle. Right bundles, by the way, can sometimes produce T wave inversion in lead 3, but really shouldn't produce the T wave inversions in all of your inferior leads. And so the concern here, is this just a plain old right bundle branch block, or is there something else going on? Well, it's not a plain old right bundle branch block pattern because there's a little ST depression. There's also T wave inversions in all of your inferior leads. There's a little bit more T wave inversion in V2 and V3 than you normally expect. And so you might be inclined to read this as, hey, this person's got a right bundle, but they also have inferior and anteroseptal ischemia. Well, remember what Marriott said. Whenever you see T wave inversions in the inferior and anteroseptal leads together, that's a PE until proven otherwise. If you ever read an EKG as infero-anteroseptal ischemia, stop and think, is this a pulmonary embolism? And sure enough, that's what this patient ended up having. This patient had a large PE and was hemodynamically unstable. So just 3 more cases to build on top of the video cast that we did back in December 2011, which talked about T wave inversions in PE. Here's another 3 more cases demonstrating this is not an uncommon finding. Large PEs will produce T wave inversions that mimic inferior and anteroseptal ischemia. So, simple bottom line. Anytime you read an EKG as inferior and anteroseptal ischemia because of flip T waves in those leads, that patient has acute pulmonary hypertension, if those are new findings. And in emergency medicine, acute pulmonary hypertension, new pulmonary hypertension equals pulmonary embolism until proven otherwise. And chances are it's a big one. So, hope that was helpful, and I look forward to talking to everybody next week with another great EKG case of the week. Thank you, and bye for now.